Hi and welcome back to another video of Medic Notes. This video is on motility disorders. The causes of esophageal dysmotility can be primary causes like achalasia and diffuse esophageal spasm. Secondary causes include autoimmune rheumatic disorders like scleroderma, Chagas disease, diabetes, amyloid, intestinal pseudo-obstruction, and myasthenia gravis. First, achalasia usually presents as difficulty swallowing and retrosternal chest pain. It is characterized by a high loss pressure and failure of the relaxation of the sphincter. There is also poor peristalsis throughout the esophagus. Absence of relaxation and loss affects 1 in 100,000 people. Usually 30 to 60 years old, and 5% of cases occur in childhood. Pathogenesis is unknown. Theories include inheritance, and a neurotropic virus affecting the vagal nucleus may be responsible. There is degeneration of the nitric oxide secreting inhibitory neurons, and loss of the receptive relaxation reflex. There is also generalized degeneration of the myenteric plexus and vagal efferents, with loss of ganglionic cells. In the early phase, there might be vigorous achalasia and chest pain, and simultaneous peristaltic contractions. Whereas in later phase, dilatation of the esophagus with retention of solids and liquids, dysphagia and regurgitation. Liquids and solids are equally difficult to swallow, unlike mechanical obstruction. The investigations for achalasia. Endoscopy. Essential to rule out fixed mechanical obstruction, as long-standing achalasia is a risk factor for squamous cell cancer of the esophagus due to chronic stasis and retention. Barium swallow. Shows a bird's beak abnormality of the loss with a dilated esophagus. Typically there is no gastric air bubble. There may be food residue in the esophagus or no emptying of contrast into the stomach. Manometry. The key diagnostic test. Characteristic manometric features of achalasia include absence of peristalsis and incomplete relaxation of the loss with a normal or high loss pressure. Complications include nocturnal aspiration, bronchiectasis, lung abscess, and carcinoma, which develops in 3% of cases. Treatment of achalasia. Conservative management offers virtually no benefit. Balloon dilation. This works in approximately 70% of patients, but there is a 3% perforation rate. Heller's cardiomyotomy, a 7 cm single myotomy at the GOJ. Reflux after myotomy is common and many recommend combining myotomy with an anti-reflux procedure. Injection of botulinum toxin into the loss under endoluminal ultrasound control is a new treatment with limited long-term success. Second, pseudo-achalasia. This typically occurs in those aged more than 50 years old, caused by carcinoma in loss, cardia or extrinsic tumor. There is increased resistance on passing the endoscope, unlike true achalasia. Third, diffuse esophageal spasm. Of patients admitted with anginal chest pain, 30% have normal angiograms. Some of these have diffuse esophageal spasm. Retrosternal pain radiating to the jaw and interscapular region is described in the patient as clammy and pale. Manometry may reveal a nutcracker esophagus with high-amplitude peristalsis of long duration. Nifedipine and reassurance are mainstay of treatment. Fourth, Chagas disease. Chronic infection with Trypanosoma cruzi, parasite native to Brazil, causes destruction of intermuscular ganglion cells. This leads to a clinical picture similar to achalasia. It is also associated with cardiomyopathy, megacolon, megaduodenum, and megaureter. And scleroderma. Of scleroderma patients, 80% have esophageal involvement. Esophagitis is also seen in CREST syndrome, involving calcinosis, Raynaud's phenomenon, esophagitis, scleroderma, and telangiectasia. An adynamic esophagus and gore lead to the formation of a stricture. The loss is found to be hypotensive on manometry, unlike in achalasia. Medical treatment or a partial fundoplication is the treatment option. Other causes of esophageal dysmotility include rheumatoid arthritis, dermatomyositis, polymyositis, and SLE. That's all for this video. Thank you.